preparing to live stream the meeting. So once this tells us we're live, then we'll go ahead and start.
Now streaming live on YouTube.
Is that what it says?
It says that.
Oh, wow. Okay. Welcome. Preparing to live stream the meeting. Oh, so once this tells us we're live. Okay. So hi, everybody. In case you're with us today, my name is Karen Kirkness, and this is my wonderful friend and colleague, Joanne Avison. Say hi, Joe.
Hi. Hi, Karen. Hi, Will.
Hi, world. And we are so excited to come together. This is our anatomy cave where we come together and talk about a region of interest. And today we're talking about, I don't know what you would say, Joanne, we love the whole body equally, but for sure the posterior abdominal wall and continuities has got to be a top favorite. What do you think? It's kind of up there.
Yeah.
Right. So to that end, none of our sessions would be complete without a specific set of aims and objectives. And in these shorter sessions, we have one aim, just to be really clear about what we're talking about. And today it's to appreciate the posterior abdominal wall and its continuities. And the objectives that we hope to tick off today are to establish the bony landmarks of the region, and then see the soft tissue continuities and bring the hard and the soft together as a myofascial space. And we'll weave in some basic embryology, and we'll see what Joe has coined this term, Diaphragm Psoas.
Well, it doesn't exist, but it was like a challenge. We talk about the Iliopsoas and the Iliopsoas complex as if it's a thing. And I'm like, well, I want it's a part of a challenge that I raise in some of the text of my book, is why isn't it called the Diaphragm Psoas when from a fascial point of view, they are completely continuous.
And guess what? We're going to start over. Do you know why?
Yes, because you weren't recording it.
Correct. That is why.
I nearly stopped you and I thought, does she know she's not recording this?
Didn't know. So we're going to start again. Here we go. Now we're recording to the cloud as well. So hello, Joe.
Hi, Karen. We love nerding out and we love being techies, don't we?
We are doing our best. My name is Karen Kirkness. For those of you who I don't know, welcome. And I'm here with my colleague and friend, Joanne Avison. Give us a hi, Joe. Hi. And we're here to talk about the posterior abdominal wall and its continuities. We'll start with establishing our aims and objectives. So our aim is to appreciate the posterior abdominal wall and its continuities. We'll establish the bony landmarks of the region, reinforce the soft tissue continuities, and we'll also weave in some of the basics of the embryological journey of these tissues. And Joanne, I'm going to just send this over to you for the last point.
The Diaphragm Psoas, which a term I made up as a question, not as a statement. Because we talk about the Iliopsoas, and if you go to Gray's Anatomy and you look up psoas, you will be directed or referenced to Iliopsoas. And from a fascial point of view, I simply asked the question in one of the chapters in my book, which is why is it called Iliopsoas and not Diaphragm Psoas, given the continuity? So that's a question we'll consider as we go through.
Beautiful. Okay, now we know what we're doing, so let's go ahead and do it. We'll get stuck in. So it's the digital cadaver, a lot of mouse clicks, sorry, and not a lot of eye contact. The visible body virtual cadaver. And this is the anterior view, and slowly we'll peel away the layers and we will get to the front of the back. Does that make sense?
Yep.
Okay, so when we go to the posterior abdominal wall, we have to actually remove the anterior abdominal wall, hiding these layers. So let's name them as we go through. So you've got your external obliques, and those fibers will be arranged in a downward slope toward the midline, moving through the rectus sheath with its lovely tendinous intersections and the linea alba. along with transversus abdominis. So here we go, a deep dive. Luckily, the viscera have been cleared out for us, because that is nobody's favorite job, getting all of the viscera scooped out, like scooping out the innards of a pumpkin before Halloween to carve your jack-o'-lantern. So away we have moved the viscera, and now you can see some of the structures in the back. And before we get rid of the neurovasculature, let's just appreciate it for a moment. So appreciating those giant vessels, the descending aorta with all of its trunks that supplying blood to the abdominal viscera and to the pelvic viscera. And then the vena cava, the inferior vena cava is there. So shall we fade these? We happy to fade them, Joe? You all right with that? Okay, so turning off.
But just please stay aware that from a fascial point of view, they are part of the, how would we call it, suspensory ligamentous structure of the viscera. It was lovely the way I think you described it on Friday when we did the visceral cavity, that they're not, it's not like a bag of shopping where you just pile things on top of each other. I think sometimes people think that what's inside us is just like piled in to a bag, the peritoneum. It's not. And the other thing I know is that I've been in hospital with my mother on one occasion, and she was looking at a picture of the viscera on the wall, and of course it was highly topographically organized to look, you know, how we have a tube map is reduced to its angles and lines, and there's this picture of the duodenum and the jejunum and all the viscera, and it's all very perfectly organized. And she said, is that what it looks like when you dissect? And it was like, no.
It all kind of hangs from,
as if, yeah, so it all hangs from the back, and it's all in this beautiful suspensory ligamentous structural system, and that includes those structures that you've just removed. The circulatory vessels are part of that intrinsically woven 3D tapestry. That what would you call it? I don't want to call it scaffolding, because that's what
it's the mesenteric ligamentous system that connects all of the organs together and hangs them from the back, and then also provides the route for blood and circulation and innervation. So it's all been nice
infrastructure, but it's been nicely cleaned away for this. Yeah.
So we've got a good view now. I thought maybe we would leave on the internal oblique, but then I removed it. And now we've got to the deep layer of the abdomen on this side. So I removed the internal oblique on that side. And how about we keep it on this side, but we fade it? Because really, in a sense, that internal oblique, can you see how it follows all the way around the back and actually does tether into the thoracolumbar fascia, which forms the structure in the main for that posterior abdominal wall. So thoracolumbar fascia is quite often we think about it as just this stuff. It's as just the tendinous insertion of latissimus dorsi, because that's how it's always pictured in these diagrams. But actually, the thoracolumbar fascia is continuous with and ensconces all of these structures. And it's continuous with all the layers of the abdominal membranes, the internal obliques, the external obliques, transversus abdominis. You know, it is all continuous. But I'll leave on the internal oblique just to leave us a remnant of that continuity, and now we can still see really clearly the ground zero back here.
And that sense that it's all held in place.
I'm just passing it to you to have a word about what's going on in the back here.
Yeah, sorry, we overlapped badly then. Yeah, I was just endorsing what you did about leaving that veil, if you like, of the oblique to give this sense of containment. And from an internal point of view, the peritoneal compartment is wrapped all around, and between that and these structures are what are called the retroperitoneal organs, which we touched on last time, didn't we? And this is, as you said, it's behind the back of the front, it's the front of the back, And we've got the diaphragm and diaphragmatic crura. So a little bit like Karen's just explained about the obliques going and wrapping all the way back round with latissimus. So we can think of the diaphragm as filling that entire upper part of this compartment, or forming the upper part of this whole compartment. But the legs of the diaphragm, the diaphragmatic crura, which are thinned out to their absolute minimum here, thank you for highlighting that, are actually in life not nearly so cleanly designated. And so too the anterior longitudinal ligament, which you see there, and the psoas, major and or minor, all look like they're neatly set into the different bits, and they're further back than the diaphragmatic crura. But in actual fact, this is like the tube of the outer abdominal wall. This is like the tube of the inner tube. So it's the inner tube of the inner tube wrapping the spine. And fascially, the fascia's been cut away to create separate structures, but in actual fact, in cadaveric dissection, that's a carved artifact. They're very, very closely integrated, and sometimes only defined as distinct by some of the fibrous angles. So we're often led to believe that all the fibrous angles are different, such as pectoralis major and rectus abdominis. You saw when Karen removed rectus abdominis, it looked as if it was it finished at the anterior costal rim, and then pectoralis major starts above it. And actually that's not true. That wouldn't be accurate. There are many fibers of rectus abdominis that literally come up and open into something that looks a little bit like you would draw a fountain, that continue. So when we move our shoulder away from our pelvis, there is a very distinct band of force transmission running in the same fibrous direction right the way through, even though those muscles are considered separate. And the same on the outside is true for the inside, and vice versa, that psoas major and or minor, and not everybody has two psoas minors. They're not always present. But usually they have psoas majors. They interface very intimately with the front of the spine and the diaphragmatic crura, the legs of the diaphragm.
Well said, all of that. And it really just goes to reinforce the point around when we establish the boundaries, when we want to talk about something, you do have to have a map. And Joe, I love how you talk about respecting this map as distinct from the actual territory. So what we want to do is use our map, but always remember we need to keep a foot in the actual reality of what it's like to have a body. And in the body, there are no distinctions. But here we're looking at the classical anatomical bony landmarks of a certain region, and that's the posterior abdominal wall. So we're going to define the posterior abdominal wall in its landmarks. So you can think about these floating ribs, the 12th ribs, 11th rib, but really the floating ribs as the bony landmark. And then inferiorly, we'll talk about the iliac crest, and particularly the posterior iliac crest, and following into the sacrum, the sacral promontory. So if I'll fade that, and then you can see the behind the psoas, we've got some of the bony landmarks. So it officially kind of ends along here where the ilia begin, and the sacral promontory. So all of this will be the posterior abdominal wall, the inside of the backside. Okay.
And just to say something, I'm not correcting you, but it's a word that comes up a lot, and it's very tricky because I've had questions about it in previous iterations, where the fascia is not just a mush inside of us, that there are no distinctions. What it is that the fascia is completely, relentlessly continuous. What is distinguished in its various pockets by spiral twists and mergings from different directions and interweaves from different angles and sort of multi-directional spirals, is the amount of muscle protein in something, or the bony landmark, where we might call it the hyaline plus hydroxyapatite. So in other words, if you think of the body as being architecturally made of fascia, we consider that the bones are a highly crystalline aspect of that fascia, that the cartilage is a nylon-like structure that makes it very thick and very strong, but differently organized to the other structures. And muscle protein gives it yet another behavioral pattern or structural element. And they are very distinct, but what is difficult to say is that they are also continuous. So what we don't want is that one bit of fascia, such as a spinal disc, leaks into another place which cerebrospinal fluid doesn't belong outside of. That would be a pathology.
Then you get a herniated disc or a Baker's cyst.
Yeah. And you can also get obviously various degrees of herniation, which can result in serious damage where fluids are not contained by the compartments they're supposed to be in. And this is where we have to hold paradox in our mind as a plausible foundation for understanding fascia, because at the same time as it connects everything, it distinguishes everything from everything else. But this is one of the issues that we're discussing here, is this ability to distinguish what we're calling the posterior abdominal wall. What do we mean by that? And technically, from an anatomical point of view, this is the area of territory that we distinguish with this particular map.
More like shining a light on it with a soft focus. Everything else is soft focused out. The hard boundaries become difficult to really look for in the cadaver. And if we stop sharing the visible body, and then I'll share another image. We looked at this on Friday when we talked more about the backside. So this is a view of the functional everywhereness of the thoracolumbar fascia, and that it isn't just the superficial, what you see on the backside, but it actually comes to define the whole region, and it's continuous with the organs inside. So we talked about this image in relation to the abdominal viscera because of it holds the ligaments that hold the organs in place. And this is the wholeness of that posterior abdominal wall. And you can really see, we're looking at the same view, an anterior view of the inside of the back. These are sheaths, and in this case, the fascia is a sheath that holds the contractile elements of the myofascia, the muscle protein, as Joe was just talking about. But you also have to factor in that it's continuous not only around the muscles, but through them, that collagen and its different fibrous qualities, and even the cells of the muscles themselves they all contribute to the fibrous matrix of the back architecture. And Joe, just handing it over to you on the psoas and the iliacus and the QL. I love how you talk about the QL holding the back ribbed. Okay,
it was an occasion, I think I mentioned in the last webinar, where Professor Carrie Davis, who is head of the British Association of Clinical Anatomists, I was in his lab and I said to him, can you talk to me about QL, please? Because he was having an argument with the presenter and what they were saying about it. And he had a cadaveric specimen that he'd already dissected, a prosection, in which there was there was a whole rib cage and a whole pelvis, and just psoas anchored to the top of the femur and quadratus lumborum. And when you looked at it, it actually is often quite a bit smaller than it's shown in these typical graphics, which anatomists have been known to refer to as cartoons, because they are optimal, typical explanations of something. And in real life, not only does psoas act as a continuum between diaphragmatic crura and the medial femur, the top inside of the femur, so it's involved so profoundly in walking, but integrating with breath, which we'll talk about in a minute. But QL is very often a multi-fibrous, but very small, sort of 2 finger width piece of myofascia that actually anchors the last rib to the pelvis. Now, if it's a floating rib, if it's anchoring a floating rib, it is less likely to be what we would call a postural muscle. And its structural role is much more to anchor the base of the bellows. So if you imagine turning the body on its side, QL holds that rib down towards the pelvis. And given the scalenes, I know there's various ones, but we'll talk about those another time, holding the very top part of the first rib, you have this idea of the fanning action of the bellows of the breath, which I absolutely love, because something's got to tether that floating rib. And that is why Professor Davis suggested that it's much less involved in active contractility to cause gait and postural management. It plays a role in that, but its role is actually to anchor breathing. It's more subtle, I think, than is often sold to us.
It's not typically included in the accessory muscles of breathing, of inspiration and expiration, but there is an argument that all of the thorax is involved in inspiration and expiration, and not the least is the QL and the psoas. So I think often, we're starting to hear about the psoas as being a muscle of respiration as much as it is a postural muscle. And really, because the topic of this discussion is the posterior abdominal wall, this illustration, it just gets us right to the core of things and shows us also some functional and practical insights. So if you can see the fascia along this region, is that easy enough to see, Joe? Can you, is that large enough, big enough? Yeah. Okay. So if we really focus in on this thickening, so where the abdominal membranes, the external and internal obliques and the transversus abdominis, as they tether in and moor in and attach into this tendinous thickening that contributes to the whole structure of the thoracolumbar fascia, this is so strong. This thickness is, not only is it dense, but the different layers and the different lamina, they interact. And in some phenotypes, our bodies will maintain more glide and there will be more movement. And we're talking really small degrees of range, but even just a little, it's just this attitude of having more movement. But then on the other end of the spectrum, when this region it can be really congested, you can see, that's the attachment of the latissimus. So all of these in postural yoga, which is where I'm coming from, and Joanne, you're coming from that, you've got many strings to your bow, but I know yoga is a massive one for you as well, is movement in these shoulder flexion postures, which is everything, right? It's any reaching up to begin the sun salutations. It's coming up, through downward dog even. But certainly when we're really wanting to flex the shoulders for more range in postures like back bending, all of that feeling of being limited down the side, the ground zero of it can really be nestled into this QL interface with the lateral raphe. So this is the lateral raphe that's labeled over here of the thoracolumbar fascia, where all of that activity, which ideally is all very gliding and benefits from movement.
And also, if you think of it, rather than as being a thick lump that we need to become flexible, it can sometimes be helpful, I've got a little bit of paper here, to think of it rather as very carefully folded pleats that are very close together, so they can glide on each other without losing their structural integrity. And when tissue becomes very dehydrated or tethered through scarring or any number of, as Karen said, reasons for congestion, we might be trying to do something like eagle pose, and we get the hands to here and you can't understand why there's no more range, but you're dealing with your arms and your shoulders and your elbows, when in actual fact the bony corset on its side of the ribs is actually being tethered and can't rotate and can't reach these different structures simply because it's tethered at the base. And it would be a little bit like if you imagine a bony corset that you're wrapping around and trying to pinned together that it won't open properly, it won't unfold. So there's a gliding element, but there's also the give of the nature of the weave. And I'll stop there because the nature of elasticity is so poorly understood, generally speaking. But what we're looking for is that ability to stay mobile, to stay hydrated, to bring flexibility and resilience at the same time, so we can operate on a fine balance between them, is so key around the spine, which I think is why, you know, restorative yoga is my baby, and the work of Vanda Scaravelli and her book Awakening the Spine. For her, everything is about keeping the spine alive, keeping the spine mobile, keeping the spine able to kind of, my word not hers, juice the surrounding architecture, becomes crucial in this conversation, as you've so beautifully put it, that it all comes back. I mean, if you think about it, latissimus dorsi is right down there by the lumbar spine. You've got the lumbar sacral spine in this picture, and there, that latissimus dorsi is what we basically call our wings. And look how much the wings have got to do with the pelvis, and especially those of you that are teaching older people, keeping some sort of management of flexibility in the sitting postures or in chair work can facilitate mobility in the arms and shoulders, and that's directly through this posterior cavity.
Beautiful stuff, and I love that term, juicing. And I wonder if on the video, you know, if I use this, I wonder if it's possible to draw. No, it's not letting me draw. So this area is so susceptible to inflammation as well with movement, and it's a spectrum, isn't it? It's a fine line between not doing too much but doing enough. So enough movement and enough stimulus and enough stress. We need to stress the body. It's when we subject the body to distress and strain beyond the body's capacity for a movement, that's when we get into the shades of inflammation that becomes chronic. So the body goes through cycles of inflammation, of stress, adaptations, and response in the normal day-to-day cyclical shape changes. So that metabolism of movement strain is part of movement stress, is part of the lifetime and the daily lifespan of the tissues. But it's when we are going beyond what is ideal for the tissue, the ideal load, that all of this can become really congested. So inflammation is a really important part of mobility. And I'll power down this slide now and go back to our 360 view. And Joe, I thought maybe now, should we move into the diaphragm?
Yeah, because we often think of the diaphragm as the breathing muscle, the big guy that does the breathing. And I think when we talk about breathing, accessory breathing muscles, main breathing muscles, we talk about the thoracic inlet, we talk about the respiratory diaphragm, we talk about the pelvic floor. And in yoga, we talk about it in terms of bandhas and vayus and the pranas. And it's always a much deeper conversation, a much more qualitative conversation in yoga than it is so quantitative. We tend to veer away from counting breaths per minute and data-based quantities, and more about the suppleness and the feeling of compliance. And this is where we're invited to consider the diaphragm and the psoas unity or continuity as being a really useful segue into how breathing and walking are much more intimately related than we might think. And it's not just yoga philosophy that allows us to go into this qualitative place, but it's the fact that all of this tissue is actually sensory, and we can actually feel it, and we can feel it optimizing as the largest sensory organ of the body. And from a fascial point of view, speaking of the fascia when I say that, from a fascial point of view, the diaphragm and the psoas have huge intimate continuity. And in fact, I would call quadratus lumborum the psoas first cousin. And when we talk about iliacus being that it's the Iliopsoas, this is where I put my structural integration hat on. If the psoas is adhered to the iliacus, there is very often related mild to intense pathology. So intense if there's scar tissue involved, and mild if it's simply adhesion. And when I say simply adhesion, there are ways that you can work with a combination of movement and manual intervention to free the glide between psoas and iliacus. They are not synonymous. They do not work as one. They work in a synergistic interrelation, a little bit like if you imagine a conductor of an orchestra bringing in the wind instrument, bringing in the percussion, bringing them to a crescendo so they can work together, and then taking them out and apart. If they all played together at the same time, you'd be a little bit like, oh my God, you don't know what to listen to. Well, internally, the body has this incredible ability to move appropriately, and fascia is our organ of proprioception, and psoas and iliacus are not synonymous, and they are sold, they are illustrated, and they are referenced in Gray's Anatomy as if they are. And psoas is referred to as a hip flexor. And I was with Professor Carla Stecco and Dr. Robert Schleip, where I was going frantic because it just wasn't my experience of myself or my students in the yoga classroom. And like you, Karen, seeing what's actually happening and comparing it with what's written in the books is like, what's that about? And it ignites the curiosity that defines both of us. I think we actually write each other anatomy nerd texts like, what do you think of? I mean, seriously, it's an illness here. Anyhow, just to say that I don't think it's a useful assumption that psoas and iliacus do the self same thing. And what Robert Schleip said to me on that occasion was, don't think of it as a hip flexor, think of it as a spine stabilizer. And that's a great big huge statement, because psoas is capable, as you know, in any yoga posture, say Janu Sirsasana or Lord of the Dance, or anything in which you're doing something very different, tree pose, different on one side to the other. Psoas plays a part in both the bent leg with the heel at the groin opening outwards, or if you're in Janu Sirsasana, in the opening leg, as well as the straightened leg or the standing leg. It plays a role in both, but it does very, very different things from one side to the other. And so I found it incredibly helpful to hold it as a spine stabilizer, because then in my mind, I think I was more accurately relating to the sensory feedback that I get while I'm actually in practice. And that's the key for Karen and I in this work, is to bring you the classical anatomy, but put it into connected terms for the practice of the territory, and not just reduced to the standardized map. Because I think we can lose our way trying to reduce our experience to the size of a map. It just won't reduce.
I love the way that you talk about the symphony and the different instruments, and that they merge in and out of one another. So the sounds are distinct, but they are so involved and interconnected. And you know, when you look at a map of the territory such as the one that we're looking at just now, you can see, compared to the previous illustration, how it's so separate, and it isn't even shown here how these muscles they live in these very, very distinct pockets of connective tissue that we know to be the thoracolumbar fascia, how it actually wraps around and ensconces and nestles in like the pockets of an advent calendar, but all around and wound around one another. That those pockets are as functionally important as the actual contractile bits themselves. So you're seeing the contractile bits, you're seeing what goes in the pockets, but you're not actually seeing the pockets. So that's important to keep in mind as we compare those these graphics. They're different, aren't they? And when we look at the soft tissue boundaries, and the main soft tissue boundaries we've discussed already are the psoas, the major, and some have the minor psoas. And then the QL, which Joanne has talked about brilliantly. It looks huge here, but you know, she mentioned it's the variability in size is
and ply, because sometimes it looks as if it's the other way, and it's actually just holding the base of that lowest rib to the top of the iliac crest, the posterior superior iliac spine, and it just doesn't look that big. It
No.
doesn't have that feeling of, there's actually something happens with these pictures. It's quite remarkable. You lose the sense of how much space the spine takes up in the lower abdomen, and you gain the sense of how huge the QL is, when in actual fact it's a bit the other way around. It's better when you do it like that. It's funny, isn't it? It's very deceptive how we learn anatomy in the flat square images, and the feeling in the body that you can when you've done something to a living body, when you've pressed on the anterior L5S1, when you've touched that from the front, which is possible if you know what you're doing, you're amazed at how close to the surface of the abdomen in a relatively thin person, because adipose tissue can make that more distant, but you get such a sense of how far into the body cavity the lumbar spine actually is.
Right. That's incredible. I don't actually work, I've never worked as a manual therapist, so I love to hear your insight from that point of view, actually using
Very thing to do. Tom Myers taught me that, and it was like, oh my God, but it makes the most massive difference. The tiniest touch makes the most massive difference, and you've got to know where you are and what you're doing, because there's all sorts of stuff in between, but it's what we call a 2-second piece, and in certain circumstances it can create the most phenomenal change. I've subsequently learned that I think you can make similar-ish differences with cranial work, working very carefully with the sacrum, but and anyone who does internal work will know what I'm talking about, but you have to be an osteopath to do that, and I've gathered that from them. I don't have that license, so we won't go there, but because everything is connected to everything else, you can be working very subtly on one aspect of something that, given the subtle knock-on effect, will have a profound effect on the inside. And I think that's crucial in yoga when we talk about adjustment. We don't need to make a heavy adjustment to make a big change for somebody. We can make a tiny adjustment that reorganizes their ability to calibrate and find balance themselves. And it's transformative when you realize how profoundly interconnected these important structural muscles are with the breathing diaphragm, which means the function of the breath can have such an impact on the structure of a posture in yoga or Pilates or any other modality.
Quite right. And what we don't see here is the continuity of the crura of the diaphragm. So when we're looking in, when we're shining the spotlight on this posterior abdominal wall, it's only showing the legs of the diaphragm. So this part is only showing the legs, and it doesn't contain the whole of the diaphragm. But what we're going to do is put it together for us so that we're going to see this whole thing as a structure that is continuous. So the diaphragm reflects the pelvic diaphragm below, and you end up with something that it's like a mirror image. So if you can imagine, the shape of the diaphragm is reflected in the shape of the pelvic bowl below. But what happens, of course, in the pelvic diaphragm is that it isn't a continuous partition such as the respiratory diaphragm, but it's all broken up into tiny little bits. Now, the little bits of the pelvic floor musculature, the classic like levator ani and pubococcygeus and all of these muscles that form the trampoline of the pelvic floor, those all need to have different directionalities, and the weave needs to function differently because of the apertures in the pelvic diaphragm, because of their function is different. And the apertures in the respiratory diaphragm, of course, there are holes in the respiratory diaphragm as well, but their physiology is different. So the passageway through the diaphragm has to be arranged anisotropically so that the lines are arranged in such a way as to support their function. And indeed, the function has dictated the evolution of the anisotropy, or the linear quality of the fibers in all of the different muscles. So looking at the respiratory diaphragm above, and then seeing it all reflected in the structures of the pelvic diaphragm below, albeit in different structural organization, you can see how analogous the shapes are. A diaphragm below, a diaphragm above. And as Joe so beautifully talked about, the role of the QL at the back is to QL and the whole of the thoracolumbar fascia is to keep that as like a husk of structural stability. So it all plugs in here. There's a really important convergence. It's the superhighway, everything plugging in like a switchboard. And then why does the front need to be so soft? Well, that's the topic of another of several webinars, and one of them is the ventral cavity. That's the soft belly of interaction. It needs to expand, and it needs to have the ability to flow out, to change, and to accommodate the gestation of the newborn. So as the embryo grows into a fetus and then powering through mammalian childbirth, the body plans of different species will follow roughly the same format. Soft in the front and then really fibrous in the back.
So this is the soft underbelly, obviously, of a quadruped. And their ligamentous scaffold is a little different because it's not suspended down from the spine. It's a different angle from the spine, let's put it like that. So the psoas is a slightly different creature. It's one of the biggest changes in becoming upright and unipedal, if we go with Dr. Stephen Levin rather than bipedal. And we talk about, as yogis, tree pose and Lord of the Dance, they're one-legged unipedal postures, which is why I think we need to evolve that the psoas, certainly in the human body, is more of a spine stabilizer than it is a hip flexor, because it has a slightly different role in unipedal creatures. But that's there's a lot of contention in that bare statement. And also I'd love to share one of my mentors, John Stirk, who is also an author of 2 lovely books, one that's just come out about exploring the body through yoga. And he set me off on my mission when I nearly drove Robert Schleiten nuts in the lab that day, saying, I just don't get this psoas as a hip flexor thing. It's just driving me mad, blah, 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 blah. And he said, what if we consider the diaphragm as a muscle of walking and the psoas as a muscle of breathing? That was his question to me as a very young yogi. And I was like, what if? And then I went and asked, what if? And that question carried me around the world, literally. And into many, 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 many hours, tens of maybe even hundreds of hours in the anatomy lab, as I know you've spent, Karen. Do you think they're valid questions?
It's the heart of everything we do, isn't it? There are anatomists who study gait, Grakovetsky being kind of a case in point, looking at the biomechanics of gait and the spinal engine, and this idea of not needing legs to actually explain gait. That gait is explained through and that
spirals, by the way, guys, you have to wait for another webinar for that, because Karen can talk about that till next Christmas, literally. But anyhow,
so I know we could both
get
stuck into that one, but
we did already.
The gait is this one end of the spectrum, and they're not irreconcilable opposites, but on one end we've got gait, and then on our end is the postural yoga, and that there's so much in the distinction between understanding anatomy in a different way for both applications. So with gait, we're looking at the bipedalism, walking, the biomotion of putting one foot in front of the other. I love how you've reintroduced biomotion and brought it into context around how we talk about movement as distinct from biomechanics. But that side of things is about the momentum and the angular momentum of controlled falling, and how that the one foot in front of the other is actually the 2 sides of the pelvis transferring the movement up the chain, and that the lumbar they don't rotate, but they send the rotation further up into the thorax. And so that's talking about getting from point A to point B. But on a postural side of the spectrum, we don't want to really go anywhere, do we? We're not walking anywhere. It's our intention to make changes of shape informed by
Yeah.
Convergent, yeah, expansion and convergence. So we're using that the anatomical understanding of biomotion differently. We're not going from point A to point B. We're going out and into ourselves.
And we're working a lot on our, we use the Hoberman sphere as a model of closed kinematic chains. And the reason we do that is the body is enclosed, even though, there's a hole running through it. It's a torus, effectively. It is enclosed. We're inside a skin bag. How does that work in the round as a whole? And as we know, a lot of those anatomy books were researched and presented as a result of, during the Industrial Revolution, an understanding of mechanics. So they are painted as if the fascia didn't matter, didn't count, wasn't relevant to structure, let alone function, other than the role of inert packaging, holding the scaffolding that keeps everything together, which is why I struggle with the word scaffolding, because it doesn't lend itself well. When you think of scaffolding, you tend to think of right-angled poles being bolted together, when in fact this is a multi-directional, multi-dimensional, soft tissue, liquid crystal scaffolding. That's a whole other bag of beans. And it gives us a task, if it's given us this fabulous opportunity to do these seminars, in that what we're talking about are these petals of connective tissue, in which are these muscle protein continuities that are holding this deeper structural frame on the inside that we move around and within. And it's like, so we've got to start somewhere. So we divide it up into bits so that we can talk about it. But this, the psoas, there's so much confusion around the psoas as one of the key, whenever Tom Myers is teaching about the psoas, he always bows and says, Al salam alaikum to the psoas, because it's often put across as the cobra. It comes up and into the diaphragm like the hooded head of a cobra. And it's part of this spiraling, breathing, very powerful ability to lift up out of the pelvis, which is a phrase we use in yoga. And, how many times have I heard, let your sitting bones drop down and lift up, you're breathing up through the body. And we talk in these terms, and Diaphragm Psoas is doing that, is active in that. Everything's active in that. But that which is switched on and that which is switched off are very intimate, subtle neuromuscular interchanges. And
we are into questions now, and this question relates directly to what you're talking about. So we have a question about, where does the psoas actually insert? So if it's not strictly a hip flexor and it's a rotator, I think it's really important we look at where does the psoas go. And Joe's talked about the psoas as a spine stabilizer, and you can see in the main it is attached to all the 5 lumbar vertebrae, and it's crossing over the hip joint, it's crossing over the SI joint and the hip joint. But where it attaches, it's maybe really useful to see why it's a rotator more than it is a flexor of the hip. So let's remove some of our soft tissue. So I'll go ahead and hide those muscles of the base.
I love how you can do this, because I think of it as a psoas and piriformis as guardians of rotation. And
let's look at so here we're going to look at Quadratus Femoris. This is the
one I love.
And you can see it's like holding and turning the hip with these muscles that interact with one another. And then the obturator.
Piriformis above it. Oh, and up to, well, all of them.
Oh, how about those deep 6? So there we are.
It's almost like a spiral down, so that piriformis and obturator and QF can do this with the lower back of the leg, and then psoas can do this with the upper front. Does that make sense? It's part of your spiral filaments, I know, but oh my goodness, it's so beautiful. Look at that. So
this view, you see, it's just not a straightforward flexor of the hip. When this is contracting, when we've got activity there, it's going to pull the lesser trochanter of the femur around and forward. So that's going to be an external rotator of the femur. So this is as much rotation as it is flexion anyway.
Well, I mean, I think it's so important also in something like cobbler pose. You know, when you open out the hip, that's one of the moves you will not be able to make if psoas is adhered to iliacus. It's just not going to happen.
No.
Not saying it should happen, but there should be some degree of ability to spiral in.
A question here around, well, where then does the diaphragm attach to the anterior aspect of the rib cage? So should we follow it up here and have a look? Right, so we're going to get a really nice view. There it is. So Joe, have you had your fingers in and around the deep costal margin? Tell us about your experience.
Well, it's part of structural integration is we do that, and we have to be very, very careful because ribs are actually not the hardest of things in the world. They are soft, and you don't want to be pulling on that tissue. But if you can ever so gently press into the ribs, soften, give yourself some slack and tuck in underneath and free that tissue, people can breathe differently. It's really completely wonderful. Makes such a difference. And it changes. See, I don't think of when people get uptight, and this is where the word tension becomes such an issue. I was listening to a physio the other day talking about the fact that adhesion causes tension, and it was like, oh no, it doesn't. It causes compression. Because when we use the word tension, sometimes we mean, oh, I'm all uptight. I've got so much tension in my body, I need to relax. But we talk about tension in terms of tension and compression, meaning the counterbalance to compression. And what we want is glide and the ability to do both. So it's biotensegrity is complex. But
absolutely. And it's also, we tend to get stuck into the locomotor system when really the contribution of the viscera is, you can't underestimate and play down
the nervous system where we're in parasympathetic or sympathetic. And we use the word tension as if it applies to all of it. And it depends. Tension can be the requisite part of tension compression balance. You know, if there's insufficient tension in the inguinal ligament right there, you've got problems.
Gabby, did we get to your question? Did that answer your question about where the diaphragm, that it is continuous all the way around the deep surface of the, okay, good. So it's all the way around. And then your other question about why are the right and left legs of the diaphragm different lengths? So this might be one of the last questions that we have time for today. But Joe, I actually wanted to give you a chance to talk about this because you raised this with me, the diaphragm being asymmetrical. So we know that because of the asymmetry of the viscera, it's not symmetrical inside. And so that you've got the liver, so that side, the right side of the diaphragm is higher. But what I hadn't accounted for, which was crazy because I'm obsessed with spirals, and I should have known that the diaphragm was spiral. But could you talk a little bit about the spirality in the diaphragm and how that might relate to this setup here?
Well, it's a little tricky, but let me say it like this. Imagine that you've got a parachute and you've got this whole parachute with all these tethers. I don't know if you can imagine, but in order for that parachute to really work, and this is a double dome, not just a parachute. It's not the diaphragm isn't an umbrella with a point going up where the main veins, arteries go. The
central tendon.
Thank you. It's a double dome. And if you think about it, the heart is a spiral structure. It is a band. The heart starts in the embryo as one container that is a band that wraps around itself and is placed. And it dominates the formation of the diaphragm. So the diaphragm is, if you like, a myofascial sandwich. And just as the view, that beautiful view where you showed the fascia that folds around all those, remember their tubular nature, structures, the heart forms in a spiral, and part of that forming, remember every single vessel coming off that heart, it starts here and folds down in the embryo, and then the face and throat fold up from it. And as the somites are forming down the back, the septum transversum is sent across the body to sort of meet the heart in this spiral integration in the body. So the sides then come in and round and draw it in, and the face unfolds from it as the tail goes down, and the lateral wrapping comes around the front. Lateral becomes ventral, or dorsal becomes ventral. And at the same time, ventral becomes dorsal. Latissimus ventri becomes latissimus dorsi. So there's this opening and wrapping and spiraling, and it's so multivarious that it's almost impossible to explain in a linear manner. Yet the anatomy books have tried to get it into a linear manner, and you're left in the cadaveric laboratory thinking, what am I looking at? Am I looking at an exception, or am I looking at a rule? And when you've seen enough exceptions, you start to wonder if the rules are different. Hence, thus and ergo, why the Diaphragm Psoas, why the Iliopsoas.
And I love the way you talk about it. It's like a picnic,
like a spiral. And it spirals into place and anchors. And then the space left on the right side is filled by the liver. So everyone's liver is unique. Everyone's liver fills the remaining space. That's one of the essences of liverness.
The liver is huge embryologically. It's like massive in size.
And it's one of the busiest organs of the body. It's, in Jaap van der Waal's descriptions, the most vital organ of the body, because it's making so many metabolic changes per second. Whereas the brain is actually simpler in some ways, because it's on or it's off. Any neural synapse, it's just on or off, and it needs a glial cell to midwife that. So the brain is actually simpler. But if you think about the fact that computer programming is done in binary systems and integrations, that's a very complex. That's not simple, but it's very, very different. Whereas the brain and the liver are kind of opposite ends of our vitality. The brain can't regenerate, the liver can. You can take a whole slice out of the liver, it will regrow itself. And this whole spirality, or chirality, as you talk about so beautifully, Karen, is a result of the original forming process. And what it is that you don't always see complete spirals in the body. You do in the fibers, in microscopic fibers of the fascia. Collagen and tropocollagen are spiral in nature. They are spiral tubes, effectively. But the tubes that they form by binding are sometimes on their way to spiraling. And I think that's a lovely example in the psoas that you showed before. It's on its way to spiraling to the leg, which then becomes part of the longer spiral. And the same with the diaphragm. It was sort of on its way.
The moment
it reached that part of the spiral staircase, but it's not the whole staircase. And to use your analogy from your book. So I don't know if that answers what you said, but it's we don't expect that symmetry.
No, and we're not looking for answers either. I think that point you've raised is just, it's bringing this webinar is an hour and it's coming to a close now, but that's really the point we'll leave it at, I think, is there are no answers. There are moments of an unfolding story, and it's the heart and soul of our offering is to really experience that map and respect the map as distinct from this territory. And Joanne, it's always a pleasure. I always learn something when we come together around the virtual cadaver. So thank you so much, and thanks to everyone who's joined us. Thanks for the questions today. And reviewing, just a stop share now. I'll stop share that image just to say properly, thank you so much.
Thank you.
And you can join us again in our next virtual dissection. Check the link in bio and come see us for our next topic. We have a total of 12, and we'll move through all the different regions of the body and look at how they interconnect with one another. This has been Karen Kirkness and
Joanne Avison.
Lots of love, everyone.
Bye.
Bye.